took all my, I'm not sure where we got the slides from, but they took all my slides. So thank you again to Dr. Faisal Goufi, who supplied me with the case as well. Now, I'm sorry some of the slides will be a repetition, but hopefully it's going to be a quick repetition. I will leave some time for questions because hopefully that would help. This is a case, a middle-aged man who presented with recurrent heart failure. I hope it works. It should work automatically. I'm sorry, it doesn't seem to be working. Anyhow, you can see clearly that he has a significant paravalvular leak. All right, if you go to the previous image, you can have an impression there is a defect. I don't have a pointer here. You can feel there is a defect here somewhere, and then when you go to the color Doppler, this proves that there is a significant paravalvular leak. All right, so the paravalvular leak, I think some places they call it a paravalvular regurg, others they call it a paravalvular leak, PVL, PVR. You can choose whatever you want. It's up to 5% in the surgical valves, up to 40% in the initial transcatheter valve placement. Now it's gotten much less, maybe probably about 15 to 17%. The good news is the majority of them are asymptomatic. The commonest symptoms, if they become, is actually heart failure and hemolytic anemia. So hemolytic anemia per se is an indication for closure of a paravalvular leak, even if they have no other symptoms. And what happens if you close it, their prognosis actually improves. And this is shown on this diagram. If you follow them for almost 3 years, these are the guys who had no hemolytic anemia after closure. These are the guys who had hemolytic anemia with a paravalvular leak, and these are who had no paravalvular leak, and clearly the prognosis is much better with those with no leak. Surgical treatment, still an option, but it is not the best option. The reason is patients usually have comorbidities, they're difficult to redo again, they have really tissues that has been so friable and so used before. So the surgery is not really a good option. Transcatheter or percutaneous closure is the way to go. There are some criteria to follow before you do, and the most important criteria actually is there is no other indications for cardiac surgery. So if they have another valve disease, if they have coronary artery disease, then they probably should go for surgery. If they don't have a good indication for surgery, then percutaneous closure is the way to go. Now remember, if they have no symptoms, however, they have ventricular decompensation or hemolytic anemia, this is per se an indication to consider closure. Now, you have to make sure that the operators and the center is equipped and skilled in the procedures. You cannot do these procedures once a month or once a year in a center. They really have to have experienced people who know how to use it and how to deal with the complications with it. Now, if you have an endocarditis, this is a big no-no for a paravalvular leak. If they have instability of the prosthesis, that's really important to make sure that you don't touch it, otherwise the valve could get completely damaged. You have to make sure that they don't have a central valvular regurg. Okay, because if they have a significant central valvular regurg, then they should put probably for surgery for fixing both. The echo is still the gold standard for diagnosis, for the assessment of the paravalvular leak, assessment of the ejection fraction, and also assessment of other valvular regurg. You really have to take multiple views, and you have to take off-angles views sometimes to assess it. This is an example of a TAVR patient. There is a small, tiny paravalvular leak, but if you change the images and you look at a different angle, you see a more significant leak. This could be completely missed if other images and off-axis views are not done. Sometimes you really have to go for invasive procedures. This is a patient who has a small, probably mild to moderate paravalvular leak both sides. He was getting progressive heart failure. The echo did not help. Patient went for a cardiac catheterization and direct measurements of the left atrial pressure. And you can see that the mean left atrial pressure is almost 40. This guy improved significantly after the paravalvular leak were closed. As mentioned previously, the CT has been recently introduced into it. It does an accurate assessment of the regurg volume, the mechanism, and the Panis formation. There is what we call a fusion CT, where we can get the CT overlap the fluoroscopy, and it does help. In this particular instance, if you look at the fluoroscopic images, and this is the fused one with the CT, you can see the paravalvular leak here on top of the valve, and this is how the wire was introduced through this segment with the help of the fusion images. It's a 2A indication to close the paravalvular leak if you have severe symptoms, unexplained decline in left ventricular function, hemolysis in a patient who are at a high surgical risk with suitable anatomy to do it. So it's a class 2A indication to be considered. These are the equipments you need to do, a lot of equipments. I don't do it, hopefully we will do it someday, but these are all the things that you need to make sure you have it. Different catheters, different sheets, different wires, and of course, different plugs and different sizes. The common devices, as been alluded before, the commonest one is the Amplatzer vascular plug, AVP. In the United States, they have 2 and 4. In Europe, it's mostly 3, and you have seen the pictures for that. It's an ethanol-based retention disc. Usually, it goes within a 4 French or a 6 French catheter. There is an Oculotec PLD. There is the Amplatzer ductus arteriosus plug, and there is a VSD plug. There is no selection guidelines available in the literature, so it really depends on the operator experience and the comfort. In general, the sizing of the occluder, there isn't as well any guidelines for that, but most people will take a 2 times the size of the defect detected by echo. Of course, you cannot use a balloon sizing for it like what we do for the PFO and the SD, because it's going to make the plug, the hole bigger, but it's 2 times the size of the defect on the echo that is used to measure it. Multiple occluders most of the time are needed. The average is 2 to 3 occluders. For the mitral valve, the procedure is done under general anesthesia. It is TE guided. The commonest is the transseptal axis, which is the standard. However, a transfemoral arterial axis and apical axis has been also employed, and I'll show you a couple of cases for that. This is an example of the paravalvular leak. On 3D, you can see a big hole. This has been shown before similarly, and this is before the closure, and this is the device after the closure. This is what they call a transcatheter rail or an AV loop. This is you go transseptal, and this transseptal, you get your wire back and get it through the aortic valve and up down to the femoral. You snare it from the femoral artery, and you come down, and you have a big loop starting from the femoral vein, looping around, coming out through the artery, and coming out through the femoral artery. And now you have a big loop you can play with and pull and push your occluder if it doesn't go easier. The outcome of the procedure is actually pretty good. 80 to 90% success rate. You have less than a mild leak, mild or less leak, that's a success story. However, it is at a price of 2 to 2.6% can get a stroke, 2.5% can get a device embolization, bleeding in up to 5%, death, urgent surgery, probably 0.8 to 1%. Leaflet impingement, which is the commonest cause of failure, actually is about 5%. This is why the assessment of the valve function at the end of the procedures, as mentioned before, is an extremely important thing. You really, with the bigger plugs, you have to make sure that doesn't impinge the valve function, and with the smaller plugs, you have to make sure that they don't embolize and they tuck very well before you release them finally. This is an example of one of the studies that shows survival is definitely better if you have no residual MR after the plug. Moderate to severe MR, the survival goes up to about 30% at 3 years. However, it's up to 70% if they have no or mild mitral regurg left after the closure. This is a gentleman who had recurrent heart failure. He has a mechanical aortic and mitral prosthesis with significant mitral paravalvular leak. You can see the leak here clearly. This is the catheter going transseptally. Now, the procedure for this guy, because of his position of the leak, it was on the posteromedial side, it was difficult to go transapical and direct the catheter down to it. As well, it was difficult to go through the aortic valve because it's a mechanical prosthesis. So the only option to close it was going through the apex, and you can see the surgical instruments here. This is another view, a mechanical mitral, a mechanical aortic valve, and this is the pulmonary wedge catheter. This is the catheter passed through the defect. This is the small, I think, a 4 French catheter through. This is the sheath. And then you get the sheath up all the way through the catheter through the stiff wire. And the stiff wire is, you see it rounding around in the atrium. Same picture as well. And then this is the plug before it's deployed. And this is the first plug. It is deployed in place. This is the emplacer device 1. And as we said, most of the time they need more than one plug, and they have more than one defect. So this is a second plug, which is getting prepared. He still had residual significant leak after the first one. So this is the second plug, and this is the final result placed after the 2 plugs are in. So in general, paravalvular leak is becoming less common. The standard treatment is percutaneous closure of the defect. Hemolytic anemia is an indication for closure. Success rate is high. However, you have to make sure that they don't get complications at the end of the procedures, especially impingement of the valve or embolization of the device. This is the final result. Minimal paravalvular leak from the initial picture you saw. Thank you very much.